Sandy, I'm just going to do a little bit of housekeeping and then I'm going to hand it over to you so we can go ahead and get started in the interest of time. If you guys will all mute for me, and if you want to keep up with the chat as we continue the conversation and throw things in there like where you're from, it's always fun to figure out where the person is coming from the furthest. So if we've got anybody who's currently logging in out of state, throw that in the chat, and we will go over some other housekeeping things at the end. But for now, I'm going to hand this off to Dr. Sandy Duke, who is the president of ACHE of Georgia.
Well, thank you very much. Good afternoon, everyone. Happy Thursday, and thank you so much for joining us. As Bonnie said, I have the privilege to serve as the president of ACHE of Georgia for 2026, and really excited in celebration of Black History Month. We are hosting this webinar today in partnership with NAHSE, NAHLE, HIMSS, and HFMA. Just a housekeeping item on our side of the house. If you're ACHE member, this does qualify for 1 hour of ACHE qualifying credit. So be sure that you claim that hour for being here today. So really, again, excited about this year ahead of us in this webinar today. So without further ado, I'm going to turn it over to my colleague, Christopher Cunning.
Good afternoon, everyone, and thank you so much for taking time out of your busy schedules to be a part of this very important conversation that we're going to have as a part of Black History Month. My name is Christopher Cunning, and I'm so honored to serve as today's moderator for today's conversation, Strategies for Bridging the Healthcare Trust Gap in Black and Brown Communities. And before we dive in, I want to take a moment to acknowledge why we're here and when we're here. Black History Month is not just about celebrating, it is about confirmation. It's about confronting the truths we rather not actually speak about, confronting the systems we're allowed to persist, and confronting our own roles, whether through action or actually inaction, in perpetuating harm or building healing. Today, we'll confront one of healthcare's most stubborn and consequential failures, the trust gap. The gap that didn't appear by accident, but it was built brick by brick through centuries of medical exploitation, from the horrors of experimentation on enslaved people to Tuskegee, to Henrietta Lack, to the forced sterilizations that continued through the 70s. And it persists today in maternal mortality disparities, in arithmetic biases, in the pain that goes untreated because it's not believed, and in clinical trials that still don't reflect diversity of patients who will ultimately use those treatments. We can't fix what we don't name, and we can't heal what we don't acknowledge. So today we gather not to perform our commitments to equity, but to practice it, to listen, to learn, to be uncomfortable, and most importantly, to commit to doing something different when we log off the screen today. I want to welcome each of you who have chosen to spend an hour with us, whether it's a healthcare executive, a clinician, an IT professional, a student, a community advocate, or someone who's personally experienced what happens when the system fails to earn your trust. Thank you for being here. Your presence signals that you believe in change is both necessary and possible. And I also want to extend my deepest gratitude to our distinguished panelists who have agreed to share not only their expertise, but their lived experiences and unfiltered insights. In a moment, I'll introduce each of them properly, but let me say up front, we've asked the leaders to bring their whole selves to this conversation, to lead with truth, not just talking points, to challenge us, not to comfort us, and to help us move from awareness to action. So thank you all for being here today. And as was mentioned earlier by Sandy, we want to thank all the collaborating organizations for taking the opportunity to sponsor this important conversation. We have a very short period of time to cover a lot of topics. And so I want to go ahead and just jump into this conversation. And first and foremost, take the opportunity to have the illustrious panel introduce themselves, their titles, and quite honestly, why do they think this is an important topic to talk about today? So I'm going to start with Lauren Powell, and then we'll go around and introduce each other. Each panel will introduce themselves. So Lauren, thank you for being here today.
Thanks, Christopher. Thank you so much to all the organizers. It's a pleasure to be here. And happy Black History Month to everyone. My name is Dr. Lauren Powell. I'm head of health equity and clinical innovation at Biogen. I've spent my career working on advancing health equity across the country in lots of different ways. This is an essential conversation that I'm delighted to be a part of today. It is one that I think we must continue to have. We have to continue to talk about the ways that trust has both been broken and the ways that trust is somehow being rebuilt in certain communities and in certain ways. So I want to talk about the problem, but I also think it's important we talk about solutions and ways that we are seeing some improvements. So thank you for having me. Looking forward to the conversation.
Thank you. Lupe Beretta?
Hey, good afternoon. Thank you so much. I'm honored to be here. Happy Black History Month. I am an improvement advisor at Grady Health System. For those that are out of state, Grady Health System is the largest public health hospital and Atlanta's only national verified level 1 trauma center. We are also one of Georgia's 8 regional perinatal centers and a level 4 maternal care center. So we are the safety net here in Georgia. I am honored to be here today. I'm also a doctoral student at Georgia State University, getting my DRPH to further expand my work. And I am the programs chair of the National Association for Latino Healthcare Executives here in Georgia.
Thank you for being here. Daria Edwards? You're on mute, Daria.
All right, I have 2 buttons that I have to push, unfortunately.
No worries.
Good afternoon, everyone. I'm Dara Edwards. Oh, got feedback. Okay, there we go. I'm actually the corporate pharmacy director for Prime Healthcare Services, and they're a large national healthcare system across 51 states, but I predominantly work and base out of the Atlanta area in Riverdale, Georgia, with Southern Regional Medical Center. And I'm involved with multiple health equity initiatives throughout our organization across several states, whether they're in rural areas or urban areas, and specifically help to promote and create health equity initiatives within the communities that our hospitals are serving, whether in Riverdale, Georgia, Clayton County, or in rural areas such as in Texas or in rural parts of Ohio and even Rhode Island. So I'm kind of speaking from the standpoint of being a part of larger conversations, not only from a health system level, but even at the state level and at the local municipality level, to ensure that our hospitals are meeting the needs of the patients in the demographics that they serve, and as well exposing areas where we might be more inclined to follow numbers instead of really assess what the community is saying about how their outcomes are performing and how they feel they're being treated and respected within our systems and organizations. So I look forward to having this conversation, and I'm grateful to be invited, especially with the panelists here. So thank you.
Thank you. Thank you, Dara. And last but certainly not least, John Matthew Douglas. Thank you for being here.
Oh, you're very welcome, Christopher, and happy Black History Month to everyone. It is such an honor to partake in this conversation and discussion today. Again, my name is John Matthew Douglas. I represent ECRI. ECRI has a long-standing legacy in safety, going back as far as 1968. An interesting kickoff where our founder, Dr. Joel Noble, who had the challenge of being faced with faulty equipment leading to the death of a patient that was part of his care. That set into motion for him a commitment to patient safety, and again has led ECRI to being the most trusted voice in healthcare today because of our independence and our evidence-based guidance in terms of the solutions that we bring forward. But again, just an absolute honor to be a part of this discussion today, and I look forward to the conversation.
Thank you. Thank you, everyone, for being a part of the panel. We have a lot to cover in a very, very short period of time. So as a little bit of a housekeeping, I'm going to ask each of the panelists to keep your responses to about 2 minutes, just so we give everyone an opportunity to, share their thoughts and insights, and we can cover as much of the topics that we have that we'd like to cover during the panel discussion as well. We know that this is just not enough time to cover this important issue, but we want to try to hit the salient points as best we can, and more importantly, give our audience and listeners a chance to ask questions as well too. So I want to jump right into this thing. So I want to talk about this thing kind of historically and then going forward for our panelists and for the listeners. So before we really get into solutions, we really need to acknowledge the depth of the problem that exists. Everyone in the Black and Brown communities hear about the Tuskegee syphilis studies and the Henrietta Lat experiments and the forced sterilizations amongst Latinas and Black and Brown communities. And not only the historical issues, but the contemporary issues we deal with pain management, mortality, maternal mortality, and a health system that is repeatedly failing Black and Brown communities. If each of you could just take a few minutes and briefly share one historical or contemporary example from your perspective that illustrates why there's a trust gap and why it matters for us to really address this topic today. And I'm going to start with Lupe.
Hey, so thank you so much for that question. I think, from my lens as an improvement advisor and a quality perspective, I understand that the institutions that we're creating, a health environment, were not designed for us. So if we look at Atlanta's history and the civil rights movement, even the structure of some of our hospitals was segregated, where white patients were served in this area, Black patients were served in this area. And that has caused a downstream effect of how we access care, how we believe what care is for us. And it in turn resulted in us going outside of the healthcare system, the hospitals, for our care. So a lot in Latino communities, you will see more holistic or non-traditional medicine that you'll lean towards, because those are where the trust comes from. And so a part of thinking about how we move forward is understanding that this is our structural environment and the environment created around us that has led to where we stand today.
Thank you. Lauren, your thoughts on this?
Yeah, I'm going to pick up right where Lupe, I think, left off. And I'm going to answer this from a slightly different perspective and say that the structures that are outside of the healthcare system also contribute to the lack of trust that folks have. And, we have to consider that people don't just live their lives accessing one system at a time. They are constantly navigating between multiple systems at multiple time points in their life and throughout the day. And so even as we look at the contemporary moment that we're in and the ways in which government, federal government, and even local governments are operating, we see how there are communities who are being clearly disenfranchised, clearly marginalized, clearly targeted, clearly being, pushed out of this country in ways, clearly being pushed out of systems. And so all of that has an impact on how people view whether they belong in or whether they will be fairly treated when they walk through the doors of a healthcare system. So I work in biotech. And so I work for Biogen, a publicly traded biotech company. We work on bringing therapeutics to market. We work on creating medications that we hope will really change patients' lives, right? And so when we think about trust and what matters for us, we think about patients trusting and providers trusting the therapeutics we bring to market. We think about patients trusting us enough to say yes to being a part of a clinical trial. There's a lot that goes into that, right? Why would you say yes to an experimental procedure when I can't even be sure that I'm existing within a system that values my life at all? So I think we have to think more broader than just how people think about trust within the healthcare system. It's how are we being valued as a human within any system?
Thank you. Great feedback. John Matthew, your thoughts?
Wow, very powerful statements all. What comes to mind to me in part stimulated by, the responses thus far, and thinking more immediately to the statement of, the value of my life. This brings to mind for me, what I believe is like the ultimate measure of healthcare inequity, and that is life expectancy. We can look at the various, disease states that exist, whether it's cardiovascular disease, diabetes, certain cancers, and the list goes on and on. And there are clear and evidence in terms of healthcare inequity and health disparity in those areas. But again, at the end of the day, life expectancy tells us a great deal. It's profound to me because you can be living in a zip code that buttons up or butts up to an adjacent zip code, and there you'll see a disparity, anywhere from 15 to 20 years, and sometimes more. And I think that that's very profound, and I think that it is an indicator of healthcare and inequity and health disparity, and it is certainly something that we really need to dig into. And to make that difference and to make that change, I should say, it is definitely going to come from looking at this more holistically through a systemic and structural lens, and providing those type solutions, I believe, is what will move the needle in terms of healthcare inequity and life expectancy.
Thank you. And then Dara, I want your thoughts, but I also want you to expound a little bit more on this as well too. And in your role as a frontline clinical professional, what are some of these real world consequences you see with the trust gap, especially when you see things like medication adherence and patient outcomes? Give us your thoughts around that as well too.
Yeah, I'm just going to weave a thread through everything that everyone has said thus far,
Wonderful, wonderful. Tie it
because
all together.
what we have is the acknowledgement. You alluded to it earlier, Chris. We
Hmm.
acknowledge the disparities are there, and we build systems. We build broken systems on broken systems, thinking
Right.
we're solving problems that we're actually not solving. And I'm going to go back to something that everyone in Clayton County always references. Every time you talk to somebody about health disparities and some of the issues that they have here, they always go back to 1996,
All right.
because what happened in Atlanta in 1996?
Hmm. And for those
The
who don't
Olympics.
know, exactly. Hmm.
The Olympics came to Atlanta, Georgia in 1996, and there was a concerted effort to push and relocate anyone who was unhoused or low income from the metro Atlanta area, or from, I should say, Atlanta, into other surrounding areas, and Clayton County became the so-called dumping ground. And so when we talk about contemporary examples of trust and lack of human value, we find that every single cycle, whatever election cycle, and folks, please do not get distracted by party lines. Eliminate that thinking altogether. Because what happens is that when economics are a key driver, you will find out very quickly whether your life has any value and what dollar value they place on your life. And therefore, it's incumbent upon us who are working kind of frontline in these systems to genuinely call those things out and not let people get away with trying to design programs on numbers instead of solutions centered around people, because we are continuing to see have no shortage of programs, but we
Right.
certainly have a shortage of results. Our outcomes
Mhm.
tell us our failures. And if we're not allowing the failure of our outcomes to dictate changing our behaviors and our practices and the way we include community members in the so-called solutions we're delivering, then we continue to fail every single time. We cannot operate as though we are the big healthcare system that comes with all the answers to all the problems. No, we haven't even begun to understand the problems that are existing because we have not valued the lives that are affected by them. So I'm come from that perspective of genuine advocacy in that front, and I applaud my colleagues for the work that they do as well. But we have to be very intentional of bringing the people who are involved at the table to help us build and frame whatever solutions we think we're framing, and challenge the infrastructures that are constantly redesigning themselves that show the people that their lives don't have value, we need to readjust that framework.
Great commentary. And I want to wrap this kind of segment of the conversation up with a question to Lupe, based on everything you guys said. We're from a quality improvement standpoint, we have all, the theme has been we have put processes on top of processes on top of processes that don't work, that are broken or dysfunctional. From a quality perspective, how does the trust gap complicate quality improvement initiatives, specifically in safety net hospitals serving these diverse populations? Give us your perspective on that as we wrap this portion of the conversation up.
Yeah, and I think Dara said a really good job of, setting this tone for understanding the landscape around us. And when you push certain people out, it results the negative outcomes. And it doesn't matter how many processes you put in place if you don't have a health equity lens. And so I want to set us up for Georgia's statistics. So we are 42% of our births are financed through Medicaid. And so that means we're seeing patients that have socioeconomic needs, that have that fragmented of care situation set up, and they're through those insurance coverage gaps. Also, our preterm birth rate is 11%, and that's why we continuously rank at the bottom, the 45%. And our severe maternal morbidity is 99 per 10,000 deliveries. And if you don't know what severe maternal morbidity is, think of it as a near miss. I did not die, but I have had very complicated outcomes of that. And when we look at the race and ethnicity, we see that our Black infants die 1.5 times the state's rate. So it's important to tie those bridges together of this is not just a clinical failure of something that we can do inside the hospital alone. We as hospitals are anchor institutions, and we are well equipped with different bodies, but when we have communities that we have not led with their voice, then we see these outcomes. And we have to think about how we can design processes moving forward, which is what my work really focuses on, is no longer looking at the 80% metric that we hope to meet, but focus on the 20% who are not showing up, stratifying who they are who's not coming to their postpartum follow-up. When we know that 52% of maternal deaths occur after in that fourth trimester. So we have to begin to think about how we look at our data. And actually, the Joint Commission said three things about embedding equity into our system. And it is leadership being accountable, it's stratifying our data in a meaningful way, and it's access and community collaboration. The communities trust the community-based organizations. We don't have to reinvent the wheel. We do have to think about how we design interventions so that we can actually move the needle.
Absolutely. And I do want to dig into the whole concept of our own community involvement later in our conversation as well, too. So thanks for teeing that up. Let's move on because we got, again, a lot to cover. Let's talk about really the current realities and continue to double down on some of the barriers that exist. What we have seen and what you all have kind of reflected on is these very specific, tangible ways that the healthcare trust gap shows up in 2026, not just in the data, outcomes of the data, but in the daily interactions between patients and providers, the design of the health system and the deployment of these. We haven't gotten into technologies, but the deployment of technology and the disparities that exist there. We'll talk about that a little bit later. I did want, Lauren, you to share your thoughts on clinical trials have historically been overwhelmingly white, despite the FDA's guidance on diversity. What, from your perspective, are the biggest barriers that are keeping Black and Brown patients from participating in research today? And what innovative strategies is Biogen actually using to try to mitigate this?
Yes, it's an excellent question, and it's a much overdue problem that I think is the onus is on the industry to really figure this out. And I think we need to put that out there first and foremost, right? So yes, there is a gap of trust, right? But to me, the question is not about trust, it's about trustworthiness. And to me, there's a difference between the two. So if you kind of place all the blame on trust, then you're saying that it is my responsibility to just throw all of my trust into you. But on the flip side, it should actually be about trustworthiness, which is then putting the onus on the system to prove themselves as trustworthy, that you
trust is
are
earned
worthy of my trust, right? So, so that is actually our responsibility to step up to the plate and to figure out. And so you're absolutely right. Despite mandates by the FDA, well, former mandates by the FDA, mandates by the NIH, that we still see significant like disparities and lack of diversity in clinical trials. And clinical trials, we're not talking about, you know, for rare disease. We're talking about clinical trials that impact disease areas that disproportionately impact Black and Brown communities and patients. So it really doesn't make any sense. Even scientifically, it does not make any sense, right? So it is unacceptable. There are a couple of things contributing to this. There is, of course, a historic lack of trust, which is understandable, right? There are many atrocities that have happened historically and contemporarily that continue to contribute to that. So on that, it is our responsibility to build trust with communities, to do that, understanding that it will take time, that it will take investment, that it will take resource, that it will take people, that it will take a diversity of people within an organization to actually have the responsibility of doing that as a part of their job, right? Ongoing commitment and investment. As we would with any other part of the business, there has to be a strategic plan for that. So that's one part of it. But the other part is that, you know, there are some decisions we are making within industry that is making it difficult for us to actually not only recruit, but also retain diverse patients into clinical trials. So we get so caught up on just recruit. It doesn't help to recruit if you don't retain. And you have to have lots of things in place to make sure that you're retaining. So for recruitment, though, we have to think about inclusion, exclusion criteria. Are we unintentionally excluding the very patients that we need to make sure we are actually including? How would we do that? Well, if we have inclusion, exclusion criteria around maybe certain comorbidities, that are maybe disproportionately impacting Black and Brown communities. Why? Because there are challenges within the healthcare system, within being able to control certain conditions, hypertension, diabetes, obesity. If we have such stringent criteria in our clinical trials, we are going to exclude the very people that we need to include. So there are some very, you know, specific protocol focused decisions that we have to make scientifically to enable us to do the right things. But then there are some very structural decisions we also need to make around, you know, where we are placing our sites. So it doesn't help if we're only going to top tier medical institutions that are often white, that are often in suburban areas, that are often nowhere within proximity to Black and Brown communities, when we know that that patient population goes to federally qualified health centers, they go to free and charitable health clinics, they are going to community health centers. How hard is it for us to think a little bit further outside of the box and to work with some of these other institutions to help undergird their ability to become a clinical trial site? Yes, that will take investment. Yes, that will take time. But what doesn't when it comes to business, right? So, so there are some decisions we have to make also around principal investigators. We do not have enough diverse principal investigators. So that is something we also have to really work closely with organizations like the National Medical Association, the National Hispanic Medical Association. These are some of the partners that Biogen is working with specifically on some of these issues. And then, you know, just recognizing that people are accessing care in very different ways. We have a lot going on with the healthcare system right now. People are losing coverage. There's a lot happening. And so we have to recognize that people aren't accessing care the same way. So how are we thinking about innovative solutions like mobile health units? How are we thinking about ways to close the transportation gap and the rural gaps? Where telehealth is possible, where can we leverage those things?
Absolutely. There's a lot of
Chris,
pieces to the puzzle.
Chris,
Before you weigh in, John Matthew, I do want to give Dara a chance to comment on this because, as a pharmacy director, she's often the last point before the patient walks out the door, with medications. And I'm just curious what she's hearing from Black and Brown patients about why they don't fill their prescriptions, why they don't take their medications that are prescribed or seeking alternative remedies, and how do you and your team respond to that? And then I'll let you weigh in, John, if you don't mind.
Yes, so thank you for that. And as someone who comes from a clinical research background with pharma, everything Lauren said is spot on. In fact, during COVID, when we attempted to enroll patients here at Southern Regional Medical Center into clinical trials regarding medications that could be used to treat it, you would be hard pressed to get people to even sign the informed consent and agree to participate for a variety of reasons. And economics does play a role in some of these things. If you go to Cobb County, Georgia, the percentage of Black and Brown community members that are filling their prescriptions may be higher than those in Clayton County or some parts of Fulton County. Economics does play into it. A lot of the trust comes from not being fully informed about what to expect. And then when you're not fully informed about what to expect, then if you start feeling certain side effects, then you don't know if this medication is doing more harm than good. And
Exactly.
therefore you don't trust that maybe your provider doesn't have some ulterior motive in getting it because everybody's heard about how pharma pays off doctors to do this, that, and the other. The other part of accountability, in terms of just getting people engaged with their care is we do have to own where we have failed our patients, quite
Right,
frankly.
right.
And sometimes, more often than we care to admit, I see too many providers that are dismissive, that basically take a very hierarchical, paternalistic, patriarchal approach to how they deliver care, especially to minorities.
Hmm.
They're more likely to engage on a collegial level with white patients than they are with Black and Brown patients. They assume less education, less insight, and then they therefore kind of withhold information that could be valuable. They fail to engage patients in a meaningful way. And therefore, that again plays into the trustworthiness aspect in terms of people wanting to follow through on their treatment. And so we find that when we go into the communities where people are living and speak to them where they are comfortable, they open up a great deal about what works for them, their preferences. Going
Right.
back to what Lupe said about non-traditional
mm,
medication, they want you to be fully they want you to discuss those as well, because if you think that everything is in a pill and you don't endorse or embrace their complementary and alternative routes, then again, they're going to push back and say, but I don't trust you because I know I have people I do trust that are that I believe more than this provider that might have other ulterior
All
motives.
right, great feedback. John Matthew, I want to give you about 1 minute to respond, and then I want to switch over because time is running quickly, and I want to make sure we cover some other topics as well. So thank you.
sure. And I'll be very brief. What comes to mind when we talk about the economics and the impact of it, you know, we are dealing with a moral imperative when we talk about healthcare inequity. And it's alarming to me that, there's certain areas that we shine a light on in healthcare. And again, this is not to dismiss them because they're very important. But when you look at areas such as avoidable hospital readmissions, which has been projected at north of $20 billion a year, you look at hospital falls, which has been projected somewhere between 25 billion and 30 billion a year. And excuse my statement there. Hospital readmissions being at 20 billion. Long and short of it is, when we look at these important issues, there's something else that we are neglecting in this economic sphere of the United States healthcare delivery system, and that is the economic burden of healthcare inequity. Today, it costs us evidence suggests somewhere in the neighborhood of $320 billion a year. It's projected to reach by 2040 $1 trillion a year. So it behooves healthcare not to look at investing in the community as a philanthropic endeavor, but rather one of return on investment. And I believe
Exactly.
wearing that hat honestly and truthfully, not only is it going to bring into the community solutions that will make a difference, it will move the needle on healthcare inequity and or trust as well. Because folks will see within the community, it's not just talk. Folks are walking the walk of what needs to be done, or I should say, walking the talk of what needs to be done to really move the needle. So I just wanted to share that additional thought. Thank you, Christopher.
No, thank you. Thank you. Appreciate the feedback. It's very, very powerful. I want to turn our conversation to technology, technology as a bridge or as a barrier to digital health, we in this age of AI and digital equity. And I'm going to start with you, John Matthew, because you were so patient and letting us respond, the ladies respond. Your company, evaluates technology for safety and effectiveness. What frameworks and standards should be placed to ensure AI tools, clinical decision support systems, and other digital technologies are validated for not just accuracy, but for equity as well?
Hmm. Great question. There's several points I want to lean into. First of which is, it's not accuracy alone. Accuracy alone is insufficient.
Right.
Equity must be an explicit validation of criterion. Core framework elements, should include areas such as, data representative of the data review, performance stratification, bias and harm detection, human oversight. AI risk shouldn't be governed by, excuse me, AI should be governed by patient safety issues, not just technical or compliance issues. And I believe that thought process is what will help us move the needle more effectively in this, emerging world and now thriving world of artificial intelligence in healthcare.
Thank you. And I want to turn to Lupe. In the safety net hospital setting, especially with diverse maternal populations, how can healthcare organizations ensure that new technology can be implemented and leveraged that strengthens that trust in that community, in those communities?
Yeah, I think it's all about reframing our conversation, our mindset, and how we partner with our organizers and suppliers, right? So, social impact, supplier diversity, contracting with those who are focused on diversity, but also inside our hospital, we usually have like innovation teams. So I know when I'm working on a project, I had one example where we were looking at alias patients. And when we talk about trust, is why don't patients want to give their ID? Because there's fear. They think there's a financial part to it. So instead of just looking, from, improvement and how technology is just for compliance, it's how do we actually help our most vulnerable population so that way they get the care that they deserve. We know that for an example of not having confirmed ID, that causes the downstream effects, right? And it also has a financial burden and legal burden if there is an adverse outcome. So when we talk about understanding the investment as the return, it is looking at, okay, I want to partner upfront with innovative teams who already are doing the work in designing technology for diverse populations, or work within our own systems to think about how we do that differently.
Great feedback. And then Lauren or Daria, any final comments or thoughts around that? Anything that Lupe or John Matthew shared?
Yeah, I'll just add that, I think we have to be honest with ourselves. Artificial intelligence and, all the advances happening with health tech is not going away, right? It's that we're not going backwards. We're only going to continue to go forward. So the question is, how can we ensure that our communities are represented? How can we ensure that our communities know how to use these tools? I don't hear enough discussion about that, right? There will come a point in time when we will have to like rely on the use of these tools as well to actually access our own healthcare information. So I think we have to start thinking through that lens as well, and through the lens of like, well, whose data is actually powering these systems, and how do we ensure that the data that is currently not powering those systems, folks who aren't in a healthcare system that's using EHR. There's lots of folks who are in places that are still using paper records. Their records are not a part of AI systems right now. People who don't have wearables, their data is not being factored into AI algorithms. So how are we going to make sure that they are represented? I think those are questions we have to continue to ask and push on for all of this new technology that's coming out.
Great, great. Dara, did you have any final thoughts on that?
Not much other than just spot on what everyone's saying. And one of the things that we are trying to do is through various programs in the county include things such as wearables and AI, trying to really inform our population and get them involved and engaged so that they become more comfortable with these tools, and especially not missing out on the generational dynamic that can also affect utilization of these tools as well, because we do have all of our generations that interact with these tools differently with different levels of trust and comfort level. So being mindful of that as well.
Thank you. And I would just also comment, I want to see these technologies actually act as oversight for us as human beings and holding us accountable. And so as it's looking at data, it's asking, why did you deliver care differently to that patient versus another? Can it be an impartial, oversight to ensure equity and accountability is delivered across, the healthcare continuum as well? So I look forward to the day where it can provide, it can be a resource from that perspective as well. I want to move to organizational accountability, and we just have a few more minutes before we'll be opening up for questions from the audience. So if you have a question, listeners, go ahead and put it into the chat so that we can have that and be prepared to answer when we open it up for Q&A. Many healthcare organizations have published, equity statements. Some still have the courage of creating DEI committees and commitment to reducing, disparities. But patients and communities aren't really seeing proportional changes. I mean, we talk the talk, quite honestly, right? But are we truly walking the walk? And what's the gap between intention and impact, and how do we close it? So I'm going to start again with Lupe from your perspective. You work on quality improvement initiatives at Grady, which has a deep commitment to serving vulnerable populations. What does authentic organizational commitment to health equity look like from a Grady perspective? And what hard choices and trade-offs has your leadership had to make just to make sure that you meet that commitment, and so that these aren't just easy proclamations, but they're actually having a true impact on the communities themselves?
Yeah, the great question. I think authentic commitment looks beyond performative statements and actually looking at operational redesign of the systems. That's looking at how departments function. That's looking at clinical pathways. It's looking at all these various day-to-day operations and embedding equity into it. Grady is certified by the Joint Commission as a Health Equity Institute, and that's led by Dr. Yolanda Wimberly. But I think, that is the cornerstone of when we talk about moving differently. There's departments within Grady that are looking at, when we talk about supplier diversity, making sure that there's voices at the table, having an influence in where our lobbyists go and advocate for different policy changes. And when we think about it, again, from, just why invest into, these upstream drivers, it's because it has a downward financial implication as well. One of the quality measures every hospital is looking at is perinatal care 07, PC 07, if you're not familiar, it's, severe maternal morbidity that I mentioned earlier. There was a study, a national study, that talked about the cost difference between someone who has complicated deliveries versus uncomplicated deliveries. And so I did a little bit of math, and if you had like 450 patients who fell into that denominator, you are absorbing an additional $7 to $12 million into your institution. So when you think about why it is important, one, it is because it's the right thing to do, but two, it's because the more that you can save dollars and improve quality, it's how you build trust into the neighborhoods. It's how you bridge that gap when we talk about fragmented care. And so that when patients are out in the community and they see their health system, now you're not an afterthought or I'm just going there because I have to, but because this is where I see my hospital showing up in my neighborhoods.
Thank you. I did want to give Lauren a chance to comment on this. The pharmaceutical industry has obviously received significant criticism for pricing, access, and representation. What accountability mechanisms should be put in place, both internally and externally, to ensure health equity commitments translate to measurable actions in drug development, pricing, and access?
Yeah, it's a great question. I think it's very layered too. I think, we have to think about pricing is very complex. It's not only a pharmaceutical thing, it's also a payer thing too. So it's very complex. And I think that the entire system really needs to work harder on that altogether. I think that we have a role to play in that, but so do payers as well. So that's definitely something that we continue to keep in mind and continue to really strategize on, especially as we think about bringing things to market. That has to be a part, and that's really where health equity, as Lupe says, has to be built into your entire strategy, right? So it has to be more than just a statement that you slap on a website whenever you feel guilty, but it has to be something that you actually put into practice. That should be a part of your market access strategy, has to be part of your evidence generation strategy, a part of your clinical trial recruitment strategy, a part of how you write protocols. It has to be a part of everything. And so we're really trying to drive that internally at Biogen. And essentially what I'm saying is that this has to be intrinsic to the business. It cannot be something that is performative and seen as the icing on top of the cake. It has to be baked into the cake. If it is not in the cake, it's not actually going to last. And that's what's happened is we have seen, organizations after the murder of George Floyd, everybody felt guilty, wanted to write these flowery chat GPT statements about how they care about suddenly health equity and they care about Black and brown communities. But you put it out there, but then how do you put it into practice? And if it's only seen as philanthropic giving, if it's only seen as something you do when you feel guilty or you feel like you've made amends because you wrote a check and you sponsored something, in the community, and that's we've done it. That's good enough. We've checked the box.
And is it sustainable? And is it sustainable?
That is not sustainable.
It's not sustainable. Yeah.
That is not sustainable. That's also not actually doing anything. Are you taking accountability? So there has to be accountability, there has to be sustainability, and it has to be an intrinsic part of the business. It has to be tied to economics. So if you don't do this the right way, you will lose or you could gain money.
Absolutely. I would love to have all of you weigh in on this, and I had at least 10 more questions to ask, but we are close to the end of our hour. And I do want to open it up for Q&A from our listeners. And we've got a couple questions here that I do want to get to. And I would encourage our panelists to read the questions. And some of them I'm just not going to be able to respond to because I do want to give you guys a chance to wrap up as well too. So please, if it's directed directly to you, if you wouldn't mind typing a response, that'd be great. I do want to answer, at least get you guys to answer George's question. And he says, in what ways might politically driven changes, i.e. DEI, to health policies contribute to unequal access to care, erode public trust in the healthcare institutions, or create confusion amongst patients and providers about available services? Great question. Anyone wants to take a stab at that one?
I would like to go ahead and kind of chime in with that because in tying in the things that were already said. So before we had the language of DEI, We simply had the systems existing as they were. And when, as Lauren said, when George Floyd happened, then all of a sudden we have all of the DEI, and they basically created everyone's form of frosting that they put on top of the cake that wasn't baked in. We need to look beyond whether there is a policy or a law and consider that our systems were not built on the people that they were called to serve. We don't need language of DEI to tell us that it's inhumane to not treat people equally, equitably, and ensure that we have the outcomes that should reflect the type of systems that we are intentionally designing around people and not just around dollars and cents. So I would personally argue that while we do have to do work at a policy level, the majority of our failures are not because of political policies, even though there are structural inequities because of politics. It
Right.
ends up being certain infrastructure failures that fail to connect, for example, pharmaceutical to the payer, to the pharmacy, to the hospital. Our corporate infrastructures have enough power within themselves to coordinate and collaborate effectively if we have the will to do so. So I like to challenge our mindset around not focusing so heavily on political willpower, but organizing ourselves around the infrastructures that we are involved in every day and seeing what kinds of changes we can do instead to break down those silos that tend to be more of a barrier than most of the legislation that we encounter. And that's just my
Right.
thought.
Thank
I
you.
just want to,
Oh, go ahead, Lupe.
yeah, I just want to, echo what Dara is saying. I often say that these are results of workflow failures and systemic failures. I will like to add, however, that is a very true statement. I wholeheartedly believe it. But as far as health policy, whatever side of the coin you fall under, healthcare will pay the consequence of it. I led HB 41, the reversal of Roe v. Wade task force, and it was all about how do we respond to this legislative law that's been put in place. And to your point, Dara, it was all about workflow, connectiveness, understanding, and how do we empower people so that way care is not, is safeguarded. And I think for us as healthcare leaders, for us in these organizations like NAHLE and NAHSE and so forth, it's understanding that we do have the anchoring knowledge of what this community around us needs to see. Right? We have the data. We understand the technologies, and we do have that ability to say and stand. And that's why you see, I think, more hospitals and more, associations showing up at the capitals and trying to, plead and revise these legislative pieces. Because even in the best intention, like when Georgia had Senate Bill 46, which was supposed to be well intended, it did not represent even the voice of current, guidelines of that. And so it's just like you miss the whole, clinical portion of and their voice. So it is important for us to realize that we do need representation and voice at these decision makings because it's happening and we are stuck figuring out how to navigate through that.
I completely agree. We talk about social determinants of health all the time, but there's a term that is framed political determinants of health, right? What are those policies and legislation that has a direct impact on the quality and delivery of equitable care amongst all communities as well, too? And so, to your point, we still have to be advocates to make sure that these policies don't do harm but help to support and create resources so that we can start changing the narrative as well too. We've got 3 minutes left, literally, and I do want to give. We have one more question that I think we can take, and I'm just going to ask one of our panelists to respond to that. And that's from Daniel. And he says, how are organizations actively monitoring and governing AI drift as AI models change and adjust? How are healthcare organizations keeping up with validation long term that they may not reflect the marginalized organizations that they serve? Anyone wants to take a stab at that one?
I will lean into it a little bit.
Thank you, John, Matthew.
And it's a very tough question.
It's a tough question.
So it's just perspective. I hats off to the gentleman that put the question forward. The challenges that we're faced with are there's layers. One of those layers are the bias of data that goes into AI. The other layer of challenge is the data security. This can create real challenges for hospitals and health systems and providers in terms of how they utilize artificial intelligence. For example, OpenAI is believed to be not necessarily a good thing by many in healthcare because of the exposure that can occur. Most notably, when one is delving into patient safety organizations and the purpose of what they do to create environments where change can occur without, punitive harm. So, again, I think, in terms of what AI can do, there's no end to what it can do, but we have to be very cautious in the healthcare realm because not only are we faced with the challenge of the influence of bias in data in AI, but we also have to be very careful about the protection of patient information and the efforts of systems to move the needle on healthcare inequity under the auspices of artificial intelligence solutions.
I agree. And I think we have to be very intentional about
Yeah.
putting the guardrails and governance structure in place that's constantly taking a look at how AI is being leveraged, the insights and responses that AI is providing to our patients, to our providers, to ensure that it's not doing more harm than good. And we are very, very much in the infancy stages of AI as well, too. So we have to understand that we're still building this plane and flying it at the same time when it comes to AI. And so understand that it's an evolving technology that we do have to continue to have guardrails around, and each organization has to be very intentional about that. I want to stop and just, first of all, thank you to the panelists for your very unfiltered, very thought-provoking responses. We covered a lot in a short period of time, but there's still a lot to cover beyond. And I just want to challenge everyone that's on this webinar today to think about one thing you can do to make a difference in your communities. And pursue it. Take the insights and the recording, go back and listen to it again, and the insights that came from these amazing individuals, and ask yourself, what's one thing you can do to help change the outcomes of marginalized communities? And I hate to use the word marginalized because we're not marginalized. We just need to be empowered, to improve the quality of care for everyone. And I think all rising tides raise all ships. And if we improve the quality for the least in our community, it improves the quality of care for all of us as well. So thank you for your time. Thank you for our sponsors who allowed us to have this unfiltered conversation. And I'm hoping we'll have another type of event in the future where we can continue this dialogue, because this shouldn't stop with this conversation today. It should be the catalyst for many more discussions in the future. So with that, take care, and I hope to see you at an upcoming industry event as well.
Thanks, everyone.
Thank you.
Yeah.
Thank you, panelists.
Thanks, everyone.
Right.
And to Marcia, I put my email address in the chat if you want to reach out offline regarding your question.
I too look forward to reaching out to everyone. ECRI is doing some very interesting work in the area of human factors engineering, and it bodes well for moving the needle significantly on healthcare inequity. So look forward to reaching out to everyone.
Thank you, everyone. Take care.
Bye.
Thank you.
Right.
Great job, guys.
Thanks, Bonnie. I'm gonna let you close it out, Bonnie.
No, that was wonderful. You did a great job, and
Thank you.
yeah, I feel like the conversation could have gone on for another hour or two. So
Yes, still a lot
exciting.
more to cover.
Yeah, love
So
it. Great
thank
job,
you.
everybody, and thanks for putting this together. Christopher, you're such a wonderful moderator, and I know
Oh,
you're
Yeah.
passionate about
make,
making it happen. So thanks for pushing to get this going.
thank you guys
Yeah.
for
Appreciate you.
supporting it.
Let's connect with the other panelists afterwards. Great conversation.
Yeah,
Absolutely. We'll do a
absolutely.
debrief.
All right.
Great.
Thanks.
Sounds good.
Take
Take
Bye,
care.
guys. Have a good
Bye
day.
bye.
Bye-bye.
You too. Bye bye.